So here we're going to get into just quickly some of the practice models that you've all seen and are familiar with. Basically, they fall into, in my opinion, 3 categories: depth psychology, cognitive, and behavioral. Okay. In depth psychology, you have things like psychoanalytic, which is the way I'm trained, existential, you have Rogerian, Jungian, and these are what we call kind of metaphysical. Things are going on that you can't really see all the time. It's like all these factors in the background, the family dynamics, the intrapsychic stuff, the conscience, the unconscious, and the ego functions and all that. And things that aren't really, the ego functions are the only thing that are really kind of observable. In some instances, the superego functions are observable. But for the most part, things are pretty abstract. Okay. In the cognitive area, it's cognitive therapy, DBT, CBT, solution focus. What's A, B, C, D, E, F, G? What is that?
Alphabets.
I'm glad you laughed because I put that in there to illustrate a point. And the point is, there are so many new cognitive therapies that have all these special acronyms attached to them that make them sound really cool and important.
Yeah.
It's all the same stuff. Okay, now I'm not minimizing it to the extent that certain approaches have been researched and validated with certain populations, but just be careful about jumping on the bandwagon of acronym therapy, I call it, because it really, again, pulls your focus away from working with the human being. Now, I'm sure that Dr. Majesty or someone around here could find another professor who would get right up here and argue with me vehemently that I'm wrong. But that's all right, because we all have different beliefs. And if we all get good results, it doesn't matter. What I'm telling you can be challenged. I want you to challenge it. I want you to think about what I'm saying and go off and do your own research, reflecting, whatever. But I'm just giving you this information to present something alternative to what you've probably, I'm thinking you've been learning, right? Or maybe not. I mean, is this?
If I may,
Yeah.
if you drop the G, you've got rational and motive behavior therapy. Interesting.
Yep. Antecedents, right? Behaviors, consequences.
Yeah.
That's right.
So it's a real therapy.
No, it's not. I
No,
just picked
that's
it up.
not, but if you drop the G, it is a real therapy.
But his point is you can throw, I think, is you can throw letters together and it starts to become meaningless,
Yeah.
So, but I'm not minimizing, like, for example, DBT, which is very heavily researched and well-founded and excellent for certain populations. Okay?
And acronyms help me. They do. Like,
No, I'm not saying I get it. But what I'm saying is be careful with being attracted to all these acronyms. It's kind of like candy. Ooh, I want to try this acronym. that acronym.
Okay.
And then these are kind of what we would call, of course, positivist and post-positivist. And why is that?
Realist.
Why do we want to
They believe in seeing things that
They can observe it and
measure?
measure it, right? Okay, that's why insurance companies love these, because they can say, you got 10 sessions of therapy, we can measure the results, and the person's on their way. What happens when they relapse? What happens if it's just a Band-Aid and no structural change happening? Right.
Wait till your insurance.
Look at the long-term studies on exclusively cognitive behavioral therapy, and you'll see what.
That's how it is where I'm doing my intern at. So many people come back like a revolving door, and I was thinking to myself, like, what are you actually doing besides meetings and detoxing them? I mean, it should be more structured, and I'm not going to say that though. What do I know?
You're not going to say it today, but you're allowed to say it. But what you're presenting to us is your theory, your belief about what's going on and how that could change. That's what I want you to do. I don't want you just to believe what they tell you you should do. You might have to do it there while you're there, but when you leave there, you don't have to do it that way. You can become involved in your own research, your own thoughts, your own ideas. That's perfectly fine.
Policy change.
Yeah, that's what I want you to do. And behavioral, the old operant classical, B.F. Skinner, Ivan Pavlov, contingency management. These are all just behavioral management. Another thing with this is it's positivist and post-positivist because we can observe it. Are we wrapping up?
No.
Oh, okay. I want to how much time do we have?
Half hour.
40 minutes.
Okay, let's get through this quickly. I'm sorry. So basically, I was saying some of those can overlap. These are the ones some of the ones I think you can kind of use both a depth psychological approach and a cognitive behavioral approach. And you can look more into that if you're interested. So next.
So I know you said it's important to focus on using one theory, but have you...
Not necessarily, no, that's not what I said. With being grounded in
Grounded in
one
one
theory.
theory.
Right.
Do you think it's okay to switch the grounding theory you use?
Sure. Maybe let's say in your early career, you really liked one theory, and later on you thought, I'm more attracted to this other thing because of the patients I've been seeing or how I've developed. Sure.
Do you think it should change on your location, like what type of work you're doing too, or should it be universal?
No, it doesn't have to be that linear and logical. Just whatever let it unfold the way it is. I mean, so I've worked with lots of different populations, and the way I am, if I want to start working with a population, I make sure I get educated, trained, and experience in that, because you don't want to go in there blind. And actually, that's going to be an ethical rule for you too to follow. So yeah.
I initially had another comment. What theory do you find? I have two questions.
Yes.
What theory do you use most?
I am formally trained in psychoanalytic psychotherapy. So that is how I conceptualize my patients. Now, I don't see a lot of patients. I'm going to start back up here soon. But for my 11 years of teaching, I wasn't seeing many patients. But that's just how I conceptualize someone. So I understand them from the perspective of their development, their ego sophistication, their level of superego development, kind of their unconscious derivatives, how they interact with me and people in their lives and their system. So that's kind of the approach I take. But that doesn't mean I'm going to always use a psychoanalytic or psychodynamic intervention like interpretation. See, I might never get to that point because they might not have an ego that's sophisticated enough to tolerate that in the time frame that we have to work together. So what I'll do is work on an ego level. So an ego level, I mean, all these fancy terms at all kind of, basically a lot of the interventions are the same. You could say technically a cognitive intervention, helping them look at their distorted thoughts and belief system, is a function of the ego, which it very much is. So in that case, or in that sense, I'd be doing technically ego support with a cognitive intervention. So just because I conceptualize my patient that way doesn't mean that a cognitive therapist will conceptualize in the same way, but we could still be using the very same interventions.
Okay.
Then your intervention, they don't have to match your theory.
Not necessarily, but if you think about what I just said, it does match my theory because I'm working with the ego, which is who you are, how you think, your level of intelligence, your level of ability to process information. That's basically those are functions of your ego. And we all have what are called conflict-derived or latent and innate ego functions. So our intelligence is innate, but our ability to process information might not be as innate because there might have been developmental factors that contributed to that. But in some people, processing and executive functioning is innate, like ADHD. So it just depends on the person, it depends on the situation, the context, the setting. But for the most part, the way I initially conceptualize my patients is through a psychodynamic lens, but that does not mean I'm only going to use psychoanalytic interventions because not everyone is able to do psychoanalytic interventions. Not everyone has enough time. And I've done brief dynamic therapy, yes, that theory informs my interventions, but that doesn't mean I'm not going to pull in something I can use behaviorally, and actually measure with the person or address a distorted irrational thought or belief that I think might work for this person. If they're a little obsessive compulsive, sometimes they like that. They like information and they like a challenge to be challenged to do something, and then they'll do it. Yes.
I was going to ask you as an LISW, assuming that you got your LSW first.
Oh yeah, yes. Mm-hmm.
What theory did you find most useful at that
So
stage?
I always knew, this might sound crazy, but from high school I was interested in Freud. I just loved it. I loved traditional psychoanalytic theory. Then as I got formally trained, I really liked the contemporary psychoanalytic theories. It just, I really couldn't tell you right now without doing a deep dive into self-reflection why I like that so much. It probably has something to do with my own development and my own past and experiences. Of course it does. But I really can't put my finger on it right now. But, yes.
Does it also have to do with which profession you're in, which theory you might?
You mean which discipline in our field, like psychology, social work? No, not at all.
I'm sorry to point at you. So for DCFS, the person in the environment, because we're dealing with the clients and their families and what happened in their lives to have their children taken. So would you? Well,
yeah. So the presenting issues there really don't lend themselves well necessarily to a psychoanalytic intervention, but that doesn't mean you can't conceptualize them psychoanalytically, like mother-child relationship. Well, that's psychoanalytic. I mean, that's where that comes from. So yeah. So that's a good example of how you can conceptualize a situation, a person, a system, but not necessarily use an intervention from that theoretical perspective. Okay? So basically, what I want you to do is conceptualize your client before all else, and this is where you do that with a theory you've identified with, okay? And because really, you have to get to know the person in front of you, and then can you formulate your ideas about their symptoms, their pathology, because you're going to look at not only their symptoms and pathology, but like here, their ability to relate, not only with you, but people in their system, how they present themselves and their problems. Because what if someone presents them more physically, like they're jumpy, than more verbally? Like, what if someone says, I feel great, I'm all right. Or what if they say, I'm really depressed. I mean, people present things in different ways, okay? And also their willingness to engage with you. If you have someone who's not going to engage with you, how is that going to affect how you work with them? There's a lot to consider from a human perspective and a theoretical perspective versus just jumping to a theory of pathology and a matching intervention. So in other words, you start by building rapport, focusing on the person, and you gradually work your way into getting to know their symptoms and pathology, etc. And then don't focus right on symptoms, okay? It's not a linear process. So this is what much education these days, many journal articles and many books on how to do therapy lead you to believe, that you have a symptom, and then you're supposed to use this intervention in your, what is it? Toolbox, okay? And then we measure it. Oh, you're doing great after 5 weeks. Well, you ever heard of the, I can't think of it, the Hawthorne effect in research? What is that, Dr. Jessie? If I say...
It's a Hawthorne effect.
Oh, we did just have that?
Yeah.
No, Rawl, I keep thinking of Rawls' veil of ignorance stuff.
So the fact that I'm looking at you increases your productivity. The fact that I'm measuring you will increase your productivity.
Right.
So it's kind of like an extended version of the Weight Watchers phenomenon. You join Weight Watchers, you lose 10 pounds without even going to your first meeting.
Right.
Because you know, okay, now someone's going to be watching me.
That's a research bias. So if I say I'm going to measure pre and post, hey John, I'm going to have you take this scale right now to measure your depression. Then in 6 weeks, we're going to measure it again. What are the chances that the results on this post test are going to accurately reflect his improvement? Or could it be attributable to the Hawthorne effect? So that's why evidence-based alone can be unproductive and kind of dangerous. Yes?
I was just going to ask that you can answer my question with the Hawthorne effect. Like, after you leave the client, is it easy to be kind of misled that they are making progress?
Of course.
By the Hawthorne effect, and once you leave them, they may regress.
Absolutely. Yeah. Yeah. So you see how research is important to understand in your practice? Okay.
Can I just throw in a recent example?
Yeah.
From one of my clients? So type 1 diabetic, juvenile diabetic. And he reported that he was managing his diabetes well. So we took a baseline. We did the single system design. Took a baseline on how often he was testing his diabetes. And so he was getting about 46% of the time. So then we did a 4-week period where he was testing according to doctor's recommendation. And it increased, right? He got up to nearly 100% of the time. But when we got to that 4th week, and we were focusing on anxiety, which was the diagnosis, related to his medical condition, he said, you know what, my anxiety is a cover for my anger. So at that point, we stopped talking about how many times are you testing per day, and we started talking about his anger. You know, and it got into that more in-depth, what are you really angry about, who are you angry at, why are you angry at them? So that's exactly what Matt's talking about, is use that. It was very productive. It was a single system design, a very useful tool. But if we had just stopped there, we would have been successful. We never would have uncovered all this other anger, which was really causing the anxiety.
And good for him for recognizing that.
Right.
Yeah, I mean, that's pretty, well, good your work you did with him, I'm sure, what you're doing. That's a very good point, yeah. So that's the dangers with using a solely evidence-based approach. So I want you to think about it like this. It's more of a dynamic process. I want you to look at this diagram and digest it for just about a minute and tell me what you think I'm telling you here.
3 aspects that are up there, if that makes sense.
And how would that look? How would that look with someone? Let's say I saw a patient coming in with, problems with general just functioning, like getting out of bed, facing the day, and I'm thinking about what could be contributing to that and what interventions I want to use.
Some portion of the dynamics, maybe perhaps in the home, maybe they're not going to bed early enough, maybe their TV is on, maybe there are other stressors that contribute to that.
Right. So I might want to jump right in on, sleep hygiene, because the function. But what happens if there's a conflict between him and his mother, and because they adopted a child and now he thinks he doesn't have as much attention. Should I intervene here or here? Or both?
If I was just to maybe guess, I would think both, because in problems functioning and intervention, there's an overlap in the intervention and there's an overlap in dynamics. So that problem is in both parts of the diagram.
Right. So you would probably address both, but what I would do maybe is address what's most glaring first and to see if or when I can get to the other stuff. Because especially if it's an initial assessment, you kind of want to build rapport first. But if you look, all of this overlaps. The dynamics can affect the functioning, can affect the type of intervention. The intervention can affect functioning. If you focus on function, can affect the dynamics. So this is not a linear process by any means. And if you continue to think about it in a linear process, you're going to have lots of frustration. But if you think about it in terms of everything overlapping, and there is not any necessarily right linear way to do it, you're going to have more success. This is kind of what you were just talking about too with your patient, right? So there were some other dynamic factors going on. It wasn't just this linear, I have anxiety, so I can't manage my diabetes, or I have diabetes, so I can't manage my anxiety, or whatever. Now there's lots of overlap in everything you see in someone. So when you see a patient, think of this, not the former, the arrow. Think of the dynamics and the overlap. And I could add many circles to that. What else could I add to that? Micro, macro, meso, what else? Supports. Health. I mean, you name it, we can add. Education, environment, parental dynamic. I mean, just think about it. Dynamics embodies lots of those things, but there's so much more we can add to it. So when you're seeing a patient, you're seeing all that, not just that symptom, that pathology that is defined by a theory, which you use to pick your intervention. And this is the spiel I give to my supervisees all the time. Some of their eyes glaze over and others say, hey, you guys are not the eye glazers, because it seems like they left. I'm just kidding. So next, we're going to talk quickly about developing your professional identity. Now, let's be very clear. This is my theory, okay? It's not been tested. This is basically my belief, my construct. This is what I firmly believe based on years of experience supervising therapists and teaching students. There's a good way to do it, and I did call this bad, but I changed it to not so good, because I don't think it's necessarily all bad. And here's what I believe. That being grounded in a theory to facilitate a human holistic understanding of your clients is good. Okay, to solely allow conceptualizations to be solely guided by symptoms or some type of evidence-based thing you're into is not as good. And why is it not as good? According to what I just have been talking about.
Every person's different.
Every person's different? Yep. What about?
They're human.
They're human beings. Right. What else?
It's also taking an approach that one size fits all.
Yes, that's right. Hammer, saw, nail. Yes, sir.
People are truly complicated.
Yeah, yeah. Have you ever had a girlfriend, a boyfriend, or what? Right? Complicated. Right?
Understatement.
Anything else?
Girlfriend, now your boyfriend.
So I guess my advice, if I had to give it, is try to do a little bit of both, but be grounded. Really be on the good side. Be grounded, and then you can pull in from other stuff. Because we always want research to inform our practice. Because what happens if they said, 1970, they said, hey, injecting bleach into people fixes them. And then later on down the line, you realize, oh, injecting bleach into people doesn't fix them. It's actually bad. The same thing can happen in our field. We just have to, be careful consumers of research. You know what I mean? I use that extreme example because I want to illustrate to you how important it is also to still use research to inform your practice. So why is that? Here's why. Because your clients are what?
Human beings.
Right. They are not a set of symptoms and pathology. If you look at it, you can be human-focused or pathology-focused in your work. And if you're pathology-focused, you're going to miss out on the human. But if you're human-focused, I promise you, you will not miss out on the pathology.
And just to kind of throw in here, that's one way to minimize some of that outlier effect. If you're focusing on the person, you get to know the person. You get to know when they're really being authentic.
Right. And pay attention to their interactions with you, because what they're doing with you is happening with people outside of you, and we call that an extra-transferential relationship. So there are always transferences going on. And then we actually have extra transferential interventions. But most of them you use in the session with you, so you can say to them, we'll figure this out with us, so you can stop doing this out there with everyone else. So conceptualize your clients as human beings, so you can then pick the right type of interventions to implement. So pulling it all together, having a theoretical foundation helps to ensure that you'll see them as humans, and trying to match their symptoms almost kind of pulls the humanness out of the equation. Now I have 3 cases I wanted to go over, but you guys want to do it real quick?
Yes.
Okay, so here's the goal here. I've got these cases. I want you to think about how you would conceptualize this person, maybe what types of interventions you'd use, what theories you might be thinking about. And I wasn't sure if you'd understand theories as much as you guys do, so this is a really great exercise. I was just going to say in that case, just go with your gut. What would you do? How would you work with it? But let's add some theory into it, okay? So case 1 is big symptoms, case 2 is elusive problems, case 3 is a healthy mix of everything. So how would you approach each one? So here's the case of big symptoms. Do you want me to read it to you, or just want to read it yourself?
Read.
Great, okay. Johnny comes into your office for his initial visit and tells you he is depressed, ruminating about his recent breakup, and is drinking excessively to cope. After talking to him for only 5 minutes, okay, 5 minutes, it's easy to detect his extreme negative thinking. What would you do?
Tell me more about it. What would I say to him?
What would you do? What would you say? This is open. There's no right or wrong answer. Let's flush it out and process it. Great. 1, 2, 3. You.
I was just tell Johnny, tell me more about what's going on.
Okay. What would you?
I would say I'm noticing that there's a pattern in the way that you're talking. Are you noticing any pattern?
Okay. What would you
As
say?
far as the intervention method, I would try to deal with the depression first. It seems like it's causing the drinking.
So what just happened here?
You have 3 different ideologies.
But what happened? What did you focus in on?
The person.
The
problem.
The intervention, the problem, okay? Okay, you didn't necessarily. You said, tell me more about it, okay? You see how easy it is to get drawn into those damn symptoms? Right in there. You're like, tell me about the symptoms. I learned this in school. I've read this great. Don't do that. The symptom could just be a smokescreen. The symptom could be a symptom connected to nothing they're coming there for, okay? I'm sure in some ways connected. But you want to get to know the person. Johnny, it sounds like you're really struggling. I'm very interested in knowing a lot more about what's happening. But I also noticed a little bit, you're kind of hard on yourself. Use terms that aren't so jargony and clinical. Hard on yourself versus that's extreme negative thinking. Yeah.
Another thing to focus on would be to see if he thinks it's a problem. If he thinks he has a drinking problem.
Right, well, you can get into that too, okay? There's a lot you can get into. After you say, I want to know, I'm glad you're here, I want to know more about it. Yes?
I apologize. I was going to say, I wasn't going to right away say anything to Johnny. I'm going to give him more opportunity to talk so I can hear his whole story.
Would you say something to facilitate that?
Tell me more about that. When he's ruminating about his recent breakup, and he talks about his feelings and how it's affecting him, I would say things like, describe that for me so that I can have a better idea of what he's feeling and what he's thinking and how it's affecting him.
And guess what else will be going on, even if it's not conscious to you. You'll be thinking about your own relationship and how your last breakup was and how your last argument was. That will and does and guarantee will happen. Yeah, yes. Someone have a question?
The first thing I would think of being that he's going through all that, in terms of just thinking of himself, if I broke up with somebody and I was drinking excessively, you're probably not sleeping. So I would ask
Yeah, you can think of all kinds of other
basic
problems.
health questions. How are you coping with this? How are you coping with that?
But would you do me a favor? Would you ask that after you guys have built rapport?
Yes.
I don't know. I would build rapport, but I would still make sure that comes out in the first visit.
How long does rapport building take?
Depends on the client. I mean, and
Not the
it
first
depends on the population. Some different cultures, some different
Right.
ethnicities are more reserved, more.
Yep, so
less
I present
apt
to
give
you
information.
this. You're gonna build, you're right, those factors all come into consideration. But I'm gonna say this to you. If you give the patient the first 5 minutes, first 10 minutes, and then get your information later, your chances of building rapport raise exponentially. Because if you start focusing in on problems and you're the expert and you need to know everything to fix it, you're gonna lose that patient. Now what you can say if they take up a half an hour building rapport is say, Johnny, I'm still very interested in what you're telling me, but the law says I have to get this information, or my supervisor, or whatever. I'm gonna ask you some very specific questions too. And you can even say that at the beginning if you want, just to prepare them, because people like to know. If you prepare them, they're generally willing to work with you. Yeah.
I was going to say also rephrasing it back to him, like.
Reflective listening, yeah.
Yeah,
Yeah.
and that'll build
Right.
rapport, but it'll also get him to.
So yes, you're all right, and even with your wanting more information, you're thinking right. Yes, there are a lot of things that could be connected to this, and you will get to that. But give that person 5 minutes. And I'm not saying that I've done any research on this, but anecdotally, give them a little bit of time to feel comfortable with you, because they don't know what to expect. Most people, to get to your office is a huge chore. I mean, it's like, do I call? Do I not call? Do I call? They might cancel. They might the first time. It's very difficult to get to your first session. So let's look at number 2, elusive problems. So Sally's referred by her mother. She's an adult who's noticed a decline in her social skills in many settings. The decline has been gradual, but is now at the point where it is affecting Sally's general functioning. During your interview with Sally, she is coherent, able to express her concern, and is open to accepting anything her mother wants. However, she is not explicit in identifying any real problems affecting her functioning. Where would you start?
My answer is going to be the same. It's going to be with talking to the client, a lot of narrative therapy, really understanding their story and what they see as a problem for themselves.
Okay.
When I hear this story, nothing sounds alarming other than like her mom feels that.
So nothing up front sounds alarming, but in your method, you'd be able to get to stuff that might be very alarming that she's not disclosing. Yeah.
I would have her finish telling me everything and then ask her, reflecting on what she just said, kind of summarizing back to her what she said, and then asking her, to reflect on that and see, just wondering how she feels about it, because I think, just what it sounds like she's talking a lot about things, but not as much of her feelings, so just trying to.
And she's talking about what her mother wants, really. Right?
That's what I was gonna say. Just like tell me.
Mothers are always the root cause.
So.
Freudian.
I'm sorry, let him go, because he raised his hand before you.
Okay.
Go ahead.
But she could go after it.
I'm sorry, I just want to be fair.
He's so polite. So being that could be an issue, her mom issues, but would you maybe start off with that as a strength, get her to talk, well, what does your mom think about this?
Depends, you might use that as a vehicle as an inroad, or you might not. So maybe you'd say, I'm hearing a lot from you, and I understand you're struggling, or that you're maybe not sure what you're struggling, but it sounds like your mom really has been noticing some things, and what's that all about?
Right.
So, or you could, maybe let that go depending on, lots of things, and say, I just really want to, it's interesting that her mom's referring to her. I wonder why that is. Why is she not motivated? If she's identifying and acknowledging, she might have some stuff going on. It just depends. I mean, sometimes it's just a gut feeling. Sometimes it's, because you have more information on your form that you're reading about the person. But sometimes you just ask. So tell me what's happening. And then it will come out in the order that's most important to her. Yes?
Strategy for building a rapport in this situation. Remember that she's a kid, so you could probably.
No, she's an adult,
She's
actually.
an adult.
So that's another interesting twist to this. She's a young adult.
Young adult. So just remembering that she might be a little hesitant in communication. You don't want her to look at you as like an authoritative role. You want to make sure that her believes what she believes that she needs.
Because what if her mother's a strong authoritarian and said, you're going to therapy? And she might be minimizing it. So much here. It's things I didn't even think about, so you guys are saying, but there's so much in here. Okay, very good. So there really is no right or wrong answer. It's just kind of, these are tests to give you a little bit of practice, case examples. Let's look at the next one. Healthy mix of everything, and you'll see why. Andre is a successful businessman who admittedly suffers from bouts of mild depression. His depression interferes with his work, but because he's able to bring in a lot of business to his company, his occasional lack of performance due to his symptoms is overlooked by his superiors. Although Andre is able to tell you about his depression, his descriptions of his symptoms are vague, and he is a relatively poor historian. You know what that means? He just doesn't, he can't really give you much about his history. He can't connect the dots between his history and what's happening with him now. He also has difficulty making connections between his development, precipitating events to his symptoms, and his current functioning. He presents with an interest in therapy, but is not sure how it will help or what he would want to address in his sessions. How confusing is that? Go ahead.
This is,
No, you go ahead.
I think it was a dead even tie.
okay.
No, you go
No, I
first.
forgot now.
Okay, so with this individual, I would still allow, because that's my thing, I still allow him to tell his story, but I would ask a lot of closed-ended questions to kind of be able to grasp a greater picture or a more clear picture of how his depression interferes with his daily life, like asking questions like.
Because it doesn't interfere at work. So.
How you sleep, things, asking about his eating habits, asking about thoughts of suicide, or You know, is he feeling hopeless? I would really try to.
So for you, it seems like some more closed-ended questions would tighten this up so you can get a clearer picture of what's going on. And that might be the right way, it might not, I don't know. You were next and then you said, go.
Just definitely seeing where he is at, like getting him to talk about what he thinks the problem is would be good in this situation, I think.
Very good, all right. Yep, perception is reality, yes.
I'd probably start with identifying what exactly brought him to the decision to come see me.
So how would you present that to him?
Maybe like, so what brought you in today?
So what do we say?
You know that, like that.
Right.
How would I do that?
So the information you want is correct, but here's how I might do it. You know, come on in, Andre, man, it sounds like from what you're telling me, there's a lot going on. I'm very interested in your perspective of what's happening with all this. Because I'm having a hard time understanding, but I know you can help me understand you, or something like that. Because you're getting at the same information without saying what brought you in today. Come on in, tell me what's happening, let's talk about what's going on with you. I'm very interested in knowing more about that. That's actually very important, or whatever, you know. So I'd like to know a lot more about that. Yes?
Well, first thing I do, like of course, is ask the building for, just get him talking about things he's good at. Because people have self-doubt within themselves, and he'll probably bring out what he's following through just conversation.
Do you see how you all came up with different ideas, different approaches? Where does that come from?
Our ideology,
Self-awareness.
the theory.
Right,
of
everything. Who you are, your experiences in life, the theories that resonate with you, your belief systems, your constructs, your ideas, you know, and that's where you are now. You're at the point where you're really kind of merging all that together and developing your niche, who you are professionally, your professional identity. With that, thank you.
Thank you.
Thank you.